Hello to everyone. Good evening. I am Maria Pellise from Hospital Clinic in Barcelona, and it's my big pleasure to be chairing and moderating this webinar on the Back to Basics, Part 5, about chromoendoscopy, when and how to use it. And we have with us two wonderful speakers that will talk around this topic, first on the upper GI part, and then on the lower GI part. So what we will do is then we will have the first talk, and then we will have some Q&As on the first part, which is the upper GI. So I invite you to write your questions in the Q&A box, and we will try to answer them as much as possible. And then we'll have the second part that will be around colonoscopy. And again, we will open the questions for discussion, and we will discuss, we can discuss from the first and the second part as well. So please, whatever question you have, put it in the Q&A, and it's time to start. And it's my pleasure to introduce you Pradeep Bhandari, that you probably know him very well. He's in Bournemouth in UK. He's in several places at a time. Today we have the pleasure to have him here, and he's going to talk about chromoendoscopy in upper GI. So please, Pradeep, the floor is yours.
Oh, thank you very much, Maria. It's a real pleasure. I think this is a great initiative from ESGE, and especially this particular talk on basics in chromoendoscopy, because this is where the journey to therapeutic endoscopy starts. So any of you who want to become an expert in EMR, ESD, underwater, FTRD, your journey starts here. And I'll go through, these are my conflicts. So basically, there are the four main dyes that we use down the endoscope for GI neoplasia, which is indigo-carmine, methylene blue, acetic acid, Lugol's iodine. So let me show you. The first thing is we're not very good at detecting upper GI neoplasia. There's a lot of data which shows that 1 out of 10 cancers in the upper GI tract are being missed by endoscopists. One of the reasons is, unlike bowel prep, we don't routinely give gastro prep, so the stomach could potentially look like this. If stomach looks like this is the same stomach after cleaning. See, at 6 o'clock, there was an early gastric cancer. There's no chance of finding it if you have a stomach like that. So we did a randomized trial giving patients can't get pronase outside of Japan. So we gave them N-acetylcysteine and simethicone as a drink versus flush. And we found that if you give them as a drink, the mucosal visibility remarkably improves both in esophagus and stomach. So this is the basic for any chromoendoscopy, NBI, BLI, anything. This is first step. We need to do this before we move on to using any technology. And that's when, if your stomach looks like this, just a bit of Buscopan, inflation, deflation, you can find these early gastric cancers. So what are you looking for? Color changes, interruption in vessel pattern, changes in morphology like a slight elevation, slight depression, any demarcation line, convergence of folds, and any alteration in pits and vessels. The commonest dye for stomach neoplasia is indigo carmine. We use 0.2 to 0.4%. You see this lesion might not be easily visible, but after indigo carmine, it becomes very easily visible. These days, you can see the same thing with NBI, BLI, eye scan, but indigo carmine with lesions like this is very easy to find because you can see the red, the raised pattern, there's interruption in vessel pattern, and that's why this is an early gastric cancer. Actually, you can characterize most of the early gastric cancer. When you look at this lesion, this is a well-differentiated intramucosal cancer, not because I'm very clever, because I know my basics. Well-differentiated cancers are in the distal stomach. They are generally red in color. They have a background of atrophic gastritis, and they're generally raised. So this is nothing clever. These are very basics. You see these features, it automatically becomes a well-differentiated cancer rather than poorly differentiated cancer. You see a lesion like this, I would say this is a signet ring cancer, very hard to find, slightly depressed. With indigo carmine, you can see a demarcation line, And when you see a lesion like that, it's signet ring because it's in the upper third of the stomach, because it's flat or depressed, because it's pale and not red, as I showed you earlier, and there's no atrophic gastritis around it. That's what makes it a signet ring or poorly differentiated cancer. Now, there are some blind spots. The biggest blind spot is here. Don't assess this area very carefully. If you don't do a proper job, patients can retch, they can get bleeding like this, and the whole assessment is spoiled. There is a early gastric cancer. You can very easily miss a patient has coughed or you were not very careful. So be very careful when you're assessing this and get rid of all this, or assess as early as possible. I put a bit of acetic acid now around it, and you can see the stomach is going red, but this area stomach is white, but this area is going red. And here is the early gastric cancer. This is the demarcation line here. There we go. So you can very easy to miss. This is a common blind spot. Please don't ignore this. Moving on to Barrett's esophagus, I started doing chromoendoscopy back in 2003, 2004. We didn't have any dyes. At that time, we were only using methylene blue for Barrett's as well as for IBD, 0.45%. We would stain it, wait for 2 minutes for stain to pick up, then we aggressively wash for 2 minutes, and then you start looking for it. So if it was completely blue, means it's healthy Barrett's. If it starts losing methylene blue after washing, means there's a cancer or high-grade dysplasia. So this is how we used to detect in good old days. Look at the picture, 2005, 1904, 2005. Then things, but there's a lot of disadvantage. I won't go through it. It's basically not reproducible. Nobody uses it. You can forget it. The latest dye, the best dye for Barrett's is acetic acid. We use it in 2.5%, and we spray about 5 to 10 ml. What you see is as soon as you spray in Barrett's, everything goes white. You see everything is white. This is aceto-whitening reaction, because what's acetic acid doing is it causes a reversible methylation of all the cytoplasmic proteins, and then it very rapidly loses. If it is a cancer or high-grade dysplasia, it loses this whitening very quickly as compared. So if it is normal, it stays white like this forever. If there is a neoplasia like this area loses its whitening very quickly. This is very interesting. We started doing this back in 2005, 2006. Along with us, unknown to us, Christian L's group in Wiesbaden was also doing this. I've seen this being used by a Japanese colleague to assess early gastric cancer after ESGE. So I brought that to Barrett's, and we started seeing interesting results. This was our first understanding of how it works. Is all about loss of aceto-whitening. If it is a non-dysplastic Barrett's, it never goes red. It remains white. If you have high-grade dysplasia, it loses its whitening within a minute. If it's cancer, it immediately loses its whitening and becomes red. So this is how acetic acid works. You see this nodule is already easily visible, but what is not visible is this flat area around it. And as soon as you stop spraying, suck all the acetic acid, you look at this nodule, the central area has already gone red. This is cancer. So right in the center, there is cancer. Now wait for another 20 to 30 seconds, area around it. Look at this. This flat area all around it has lost its aceto-whitening as well. So there is high-grade dysplasia all around this nodule. You see that? This would have been very easily missed if you don't use acetic acid. It's a very high sensitivity, very high negative predictive value. And this was the first publication back in 2010. Both us and from Portsmouth as well as Wiesbaden produced our data. We didn't know each other. We had no idea that we were doing. And both of us, both groups came with a sensitivity of around 96%. So in expert hands, it really works very well. We then finally understood how it works, and we designed this classification called PREDICT, which was published in Gut by my research fellow Keshwan back in 2018. And it's basically only 2 features. loss of acetowhitening, absent or present. You can see here, you lost your acetowhitening, that's neoplastic. And then the surface pattern, whether it's normal or abnormal, you can see this pattern is not the same over here. Similarly, this pattern is not the same over here. Very simple. Loss of acetowhitening, abnormal pattern, that's cancer or high-grade dysplasia. Very high sensitivity when it is used appropriately. You can see some example now. There's a tiny little nodule here. You can't be sure what this is. Is this ulcer? Is this gastritis? Spray acetic acid. See, it's immediately lost its acetowhitening, but just wait for 30, 40 seconds. Look at this area around it. Everything is lost its acetowhitening. All this flat area would not be possible to see it without acetic acid. So there's high-grade dysplasia all around it. You would not see that without using acetic acid. You'll only focus with this nodule, and then you get R1, or you leave residual neoplasia. This is a long segment of Barrett's, quite long, nothing obviously visible on white light. With BLI, we could see some areas of concern. We're not really sure. You spray acetic acid. It's like finding a needle in a haystack. Keep going. Everything goes white. And then you find a tiny, tiny speck of loss of acetowhitening. Look at that. That little area here, loss of acetowhitening in that tiny little area. Everything else is white. You see that here, a little streak. That's intramucosal cancer. Can you believe that tiny little area? Without acetic acid, no chance in hell to find this little intramucosal cancer. So it's a fantastic dye, works really well. Another example on white light, you can't really see much. On LCI, you can see now a red spot, which is the area of concern. On BLI, again, you can then put acetic acid. The margins become really clear now, along with any other BLI, LCI, NBI technology, along with acetic acid. If you use in surveillance, we have reported that it increases your detection rate by about threefold. So it's a great idea. It's not a randomized trial. So we did a randomized trial as a pilot study. And what we showed was that you can reduce your biopsy rate by 10-fold reduction without any drop in pickup rate for neoplasia. So great idea to use acetic acid targeted biopsy. The number of biopsies go down. That's why ESGE recommends they use a high definition endoscope and acetic acid as a chromoendoscopy dye for Barrett's assessment for neoplasia. Another interesting example, a patient who had chemoradiotherapy for a T2 cancer comes back for assessment twice. Once it shows residual cancer, next time 21 biopsies taken, no cancer, so get sent to us. We assess this. It's horrible. It is very difficult to make out what is what in this esophagus, which is being treated by chemoradiotherapy. Your dyes your technology doesn't help much. We put some acetic acid and you will see, look at this. This is loss of acetowhitening, very discrete. And you take a biopsy here, you'll get a residual cancer in this. We can then push the boat out in these patients. Once you've delineated like this, even these advanced cancers, after being treated with chemoradiotherapy, in expert hands, you can resect it. Mark it, very, very easy to mark with acetic acid. You can see the fibrosis, but this can all be done. It's not about ESD. Let's not worry about that. In the sake of time, I'll miss it. But again, a lot of flat area around the nodule becomes only visible when you put acetic acid. Look at that. That's normal whitening. This is high-grade dysplasia around the nodule. See the margins? So it helps you in delineating the margin. Acetic acid is also being used in combination with indigo-carmine by our Japanese colleagues to detect early gastric cancer. I've tried it. I have to say it doesn't work very well in my hands, but in Japanese hands, it works really well. And some of them really use it for delineating. So final dye is Lugol. This is my favorite dye because I feel even if I lose my eyesight, I'm almost blind. If I use Lugol, I will still find squamous cancer. It's so brilliant. a 1.5%, 10 to 20 ml. Very important to warn the patient that once we spray Lugol, they could get chest pain. So don't worry about it. We can wash it off with N-acetylcysteine, or if you have soda bicarb, wash it off with that. That reduces the pain. But be very, very careful when you're using this that you stay away from larynx. If you put a drop of Lugol on the larynx, patients can get angioedema. So be very, very careful about that. You see hardly anything visible in this. You use technology, you can see interruption of vessel pattern there, but use Lugol, very easy. Every single person in endoscopy, even your patient can diagnose that there is something wrong, doc, here. What is this? So how does Lugol work? Well, Lugol gets absorbed by the glycogen in the esophagus. As soon as the glycogen takes Lugol, it goes brown like this. If you have cancer or high-grade dysplasia, cells are proliferating so fast, they eat up the glycogen. There's not enough glycogen in here, so this area doesn't take your Lugol very well. So we call this a Lugol voiding spot. A Lugol voiding spot looks yellow, and that's a marker of high-grade dysplasia or cancer. This is what you're looking for. So another great example, see, hardly visible. So I'll run this video. You can see very clean esophagus, nothing obvious, but suddenly you will see interruption of vessel pattern there, slight redness, very easy to miss. So be very, very careful in detecting this slight redness and spray Lugol, and here you go. Look at this. It was hardly visible, but with Lugol, you can see it's quite a large area of cancer there. So this is another very long squamous. Look at it carefully. There's nothing visible on white light, nothing. You put your enhancement and you begin to see few things. In the sake of time, I won't go through these IPCL patterns that you see with BLI. These are abnormal IPCLs. You see, this is the normal, this is abnormal. When you use magnification and BLI, you can see abnormal IPCLs. But you don't need this clever technology, this knowledge of IPCL if you use Lugol. Look at this. Once you spray Lugol, that normal looking esophagus shows a big circumferential cancer. It's so easy to miss out on that. Look at this. Normal and now circumferential squamous cancer. When we resected it, it came back as SM1 cancer. So easy to miss, but so easy to find with Lugol. There's a lot of data now which shows that in expert hand it is as good as NBI, or you could say NBI is as good as Lugol. But in non-expert hand, I think Lugol is a lot better than NBI or BLI. So to conclude, indigo carmine is a great dye for detecting early gastric cancer, but with the quality of scope improving, NBI, BLI, iScan improving, we're using less and less. Acetic acid still remains the gold standard for detecting subtle neoplasia in Barrett's, and Lugol, I mean, this is the best dye for detecting squamous. So thank you. I know we're not supposed to promote, but what I want to say here is if you want to know more, if you are ESG member, if you are an ESG member, please note down this discount code. You will get 50% discount only for ESG members who attended today. Thank you very much.
Wonderful, Pradeep. So thank you very much. That was a wonderful talk with a lot of cases that were super easy to see, and that the video is more than words. You can really see that it is useful and how easy it is to use it. So we have already almost 300 participants, which is great. Wow. So I hope that we have a lot of questions coming on in the Q&A. In the meanwhile, I wanted to ask you, because Chromoendoscopy had, like, as you were saying, this is quite a little bit of old data. So it looks like it's unfashioned anymore. Nobody wants to do dye-based chromo. But in view of what you were showing, it looks like it is still very useful. And what would be your advice for people that, for example, are not experienced and are starting? What would you tell them to do if they have to use that for every case? They just have to use it in the cases that electronic chromoendoscopy give them some...
Very good point. Yeah. So let's start with early gastric cancer. You can't spray the entire stomach with indigo carmine looking for early gastric cancer. You'll get super confused and you'll go crazy. So don't do that. If you find a lesion in stomach, clean up, get rid of all the mucus and assess it with NBI, BLI. And that will give you immediate idea that the vessel pattern is abnormal from the surrounding. So now when you want to delineate the margins, indigo carmine is beautiful for early gastric cancer. In Barrett's, I think if you see an obvious lesion, then use NBI, BLI to assess it. You'll be able to see and assess and make out easily that the vessel pattern is abnormal. This is neoplastic. But if you don't see an obvious lesion, those flat lesions, very difficult to find with NBI, BLI. That's where we routinely spray the Barrett's with acetic acid. Look for aceto whitening spot, loss of aceto whitening, those red spots. If you find a red spot, assess that carefully. You can use NBI, BLI after acetic acid, and then you can convince yourself this is neoplasia. You take a targeted biopsy, you move on. Lugol, only use it in high-risk patients with history of lung cancers, tonsillar cancers, tongue cancers, cheek cancers. They are at very high risk of getting another lesion in the squamous esophagus. Those patients, we would routinely spray Lugol. Otherwise, find an abnormality on white light NBI first, and then selectively spray Lugol on that area. That's the way to use it.
Thank you. That's fantastic. So, and do you have any concern with acetic acid on the airway, on the larynx? Is there any risk for that?
Acetic acid, no. Lugol, huge concern. Please do not go anywhere close. If patient is not intubated, don't drop Lugol near the airways. They will get angioedema and can get really respiratory arrest. So but acetic acid is fine, no issues.
Okay, there is an interesting question here on how to differentiate between squamous carcinoma in the esophagus compared with glycogenic acanthosis after Lugol dye, especially.
Squamous cancer will show you yellow Lugol voiding area. Glycogen acanthosis is no, it will remain brown.
Okay, perfect. Yeah, they are asking if you use Lugol only in intubated patients or if you do it also in deep sedation, unconscious sedation
you can do
patients.
with sedation. If you're doing with sedation, spray only 20 centimeters and downwards. Don't spray Lugol about 20 centimeters in esophagus. That's very safe. Then you won't have a problem. Make sure patient is not retching a lot. If patient is retching, suck first very quickly. Okay. Otherwise, just don't do it. If he's retching and uncomfortable, don't do.
And about acetic acid, they are asking if there is an erosion or an ulcer, can we still use it?
You can use it if there is inflammation, ulcer, erosion, but it will be confusing. The downside of acetic acid is it's not just neoplasia that loses aceto whitening. Even inflammation loses aceto whitening very quickly. So you will be confused. So my suggestion would be you see inflammation, ulceration, erosion, high dose PPI for 8 weeks, bring the patient back, and then use acetic acid. That's when it becomes helpful.
Wonderful. And then in the Q&A, Pradeep, there are plenty of questions on how you prepare the acetic acid solution and if you can use normal vinegar. So maybe you can write it down. Maybe you can answer some of them.
I'll handle that.
Or we can write it down because there were, or maybe you can explain it in a few words. I don't know.
Oh, it's very easy. It generally comes as 5% acetic acid. Do 50-50 dilution. We take a 20 ml syringe, 10 ml of acetic acid, 10 ml of normal saline or distilled water. Both are okay. So you get 2.5%. As simple as that. Don't shove it down the endoscope. Use a spray catheter. Don't just push it down the endoscope. Spray catheter is important. That's it.
Okay, fantastic. So fantastic. I think you did a super overview. and everybody will go home with a lot of tips and tricks, and tomorrow everybody will be using any of those things.
I'll be super happy
motivated.
because we are missing a lot of upper GI cancers, Maria. Throughout the world, colon cancer screening program has increased the quality of colonoscopy. Bowel prep has improved. Polyps are being taken care of. Upper GI cancers, we still not taken care of. So I'll be so delighted even 10% of the audience starts using something from this.
Wonderful. So we are going to move to the next speaker now and to the lower part of the body. So the next speaker is Lobke Desomer. She works in Ghent, in Belgium, in the ESGE Delta Rumbeke and Ghent University Hospital. And he also is the head of the charitable arm in GIGS. I don't know if you know GIGS, but it's a wonderful platform for learning. So she's there very much, and she's going to talk about chromoendoscopy in the colon. So please, Lobke, the floor is yours.
Hi everyone. Thank you so much, Maria, for the introduction, and Pradeep for your wonderful presentation. I'll try my best to do half as good as you. And thank you, obviously, ESGE, for the opportunity to have this to do this presentation tonight. So I'm going to talk about lower GI. I have nothing to disclose. So we all know colonoscopy is the gold standard for detection of colonic neoplasia. With removal of the colonic lesions, we find and eventually decrease the risk of the development of colorectal cancers. So we want to optimize our colonoscopy technique, and there's many things that we can do. We have withdrawal time, we have ADR, we have all these things, but one of those is obviously chromoendoscopy. Now, I'm not going to go into this too much, but I think it's very important that everybody is aware of the ESGE guidelines, and they are very worked out, thought out, detailed, and it's definitely something we should all read. And there's also a ESGE training curriculum with recommendations for optical diagnosis in specific conditions on the left-hand side for upper GI, right-hand side for lower GI. So I'd seriously recommend these publications. Now, when we talk about chromoendoscopy, we have obviously the conventional chromoendoscopy. You all know what this is now from Pradeep. So dye-based, most used in colon will be indigo carmine, methylene blue, and acetic acid, and maybe less so in the West, but also crystal violet. And we're actually wanting to highlight areas of suspected dysplasia. I'll show you an example very soon. The virtual chromoendoscopy, we all know these are the commercially available ones, NBI, BLI, LCI, iScan, with their respective companies. So what does narrow band light do? It is absorbed by vessels and reflected by mucosa, and therefore increases the contrast between the vessels and the surrounding mucosa, highlighting the vessels, and makes it easier to observe the surface pattern. So I want to try and follow this a bit, because obviously there are hundreds of publications on chromoendoscopy in the colon. I'm just going to touch upon these 3: inflammatory bowel disease screening of average risk populations, polyposis syndromes, and maybe more elaborate on polyp characterization. So in IBD, it's still used very much so for patients with ulcerative pancreatitis or Crohn's colitis. At least 1/3 of the colon affected, they have an increased risk of colorectal cancer. So we do need to screen these patients. And you can use virtual chromoendoscopy here as shown here. So we're at the cecum. in this case, it's BLI that was turned on. And we're looking for an interruption maybe of the surface of the colon, and it's quite difficult in IBD. There's scarring, sometimes there's residual inflammation. So we wanna make sure that what we detect is an actual dysplastic lesion and not just some inflammation. Now, virtual, we have already picked up in the cecum that there is a more less flat mucosa, let's put it that way. There is, we see something, but it's harder to see what exactly this is about. Now, if I would now go to the dye-based, although let's just have a quick look. You see that here, these are normal pits, open pits. Well, here it's not as clear, but in a colitis patient, it's sometimes something, sometimes nothing. So we then put chromoendoscopy, the dye-based chromoendoscopy, in this case, methylene blue, in a concentration of 0.1%. The methylene blue gets absorbed. You use a spray catheter as well, and you make these rotational movements throughout the colon. You do it per maybe 20, 30 centimeters, and it will wash down a bit. So you will not even have to spray all that much. By the time you've inspected the right side colon, a lot of the dye will already have gone to the more distal colon. So once you've sprayed that, you wait for about a minute or so, and you're gonna go back to the cecum and have a careful look. It works really well in this very well prepped colon. It's a bit more difficult when there's a lot of stools left or mucus, but in this case it works brilliantly. So we're going up to that lesion that we've previously seen here on NBI, and you can now very nicely see the normal white crypts and the blue borders from the colonocytes. But here, this lesion is actually looking quite different. So we see that we can look really close, and with high definition scopes, we don't even really need magnification. And we can see that there's definitely a different pit pattern here, and we must be, so here you can see very nicely, we must be taking at least targeted biopsies of this, maybe not too many, 1 or 2 at the edges, to not impede resection at a later time. So there is definitely a very nice example of chromoendoscopy dye-based here in IBD, and it shows the technique at the same time as well. I'll continue with screening colonoscopy in the average risk population. So average risk means screening outside the context of hereditary polyposis syndromes or inflammatory bowel disease. So we know that the additional use of high definition NBI versus high definition white light will not show really a significant increase in ADR. Versus standard white light, it might show a marginal improvement in ADR. And then for the other, the software-based filters, if I can say it like that, so data is more scarce, and the beneficial effect in terms of incremental plot detection is probably marginal. So high definition is the key. High definition scopes, as you can see on these pictures, you can beautifully see the polyp, and we don't need actually virtual chromoendoscopy to find this polyp. In polyposis syndromes, there is, again, a very nice guideline from the ESGE. Again, the emphasis is on high-definition systems, if possible. Dye-based chromoendoscopy might have a place in serrated polyposis syndrome diagnosis and surveillance, but no systematic use of chromoendoscopy for familial adenomatous polyposis, mutate-associated polyposis, or hamartous polyposis is recommended by ESGE. So I do have an example here of a rectal pouch where a large lesion was detected, and we all know in the pouch, if you look, yeah, the delineation is likely to be here, but in a pouch, sometimes the mucosa might be quite uneven, let's say, or there's multiple smaller adenomas around a larger lesion. So it might be a little bit harder to delineate the lesion with virtual, and you can use additional chromoendoscopy to delineate the lesion if it's difficult. And here you can very nicely see the delineation using dye-based chromoendoscopy. So for polyp characterization, the optical diagnosis is crucial to decide on the appropriate treatment of the lesion. We cannot treat every lesion in the same manner. So if we have a demarcated area, and I will come back to that, to what that exactly is, we will need magnification to really examine that area, because these have a higher prevalence of deep submucosal invasion. And talking about the most frequently used, I think, classifications, we have NICE, which uses NBI, virtual chromoendoscopy with NBI, and it's 3 types, as probably everybody knows, being type 1, lighter or same as the polyp is lighter or the same color as the background mucosa. Type 2, the brown, it's as brown or a little bit browner than the background mucosa, but the pattern is completely regular, and it's suggestive of an adenoma, so type 1 hypoplastic or sessile lesion. And 3, it's brown, darker brown, but some whitish areas, surface pattern. So we are, these are a type 3, and we have to be careful and look for deep submucosal invasion in these polyps. So I wanted to show you these 2 videos to illustrate this. And so you have a large non-pedunculated spreading lesion, large laterally spreading lesion. And we are actually first in white light are going to examine that polyp completely. We will determine Paris classification, morphology, granular, non-granular. I will show you later why. And we're going to then turn our virtual and look for areas which are maybe nice type 3. And we're going to do that the same on the right-hand side. We're looking for overt signs of deep submucosal invasion using white light. If we can, magnification as well gives us beautiful images. And yeah, if we don't see any signs of overt deep submucosal invasion, we will still look at other classifications. For example, the Paris, where you can see here dominant nodules. they may also be suggestive of deep submucosal invasion. And actually, the group of Professor Pellise has proposed a nice algorithm to guide therapeutic decisions for larger than 10 millimeter colorectal polyps. Very nice paper where actually we can see that endoscopic treatment is suitable to the vast majority of polyps. There is a less than 1% that needs surgery and absolutely no endoscopic treatment. And then there is this orange area, we should say gray area maybe, of lesions where we really need to personalize treatment and tailor it to the patient, and probably also the endoscopic expertise at the center. So what we see, if there's a nice type 1 or type 2 lesion with a depressed area, already we know there's 10% a risk of or prevalence of deep submucosal invasion. When we have no depressed area, but we have a granular lesion, but with a nodule, as I showed in the video before, a risk of having deep submucosal invasion is 9%. In type 3 lesions, we look, are they pedunculated? Yes, then we can definitely endoscopically resect them en bloc. 30% will have a deep invasion, but if there's any suspicion, you should obviously tattoo the area of where you removed the polyp. If the polyp's not pedunculated, we look at ulceration, and if there's ulceration, we have a very high risk of 93% of deep invasion, and we need to send these patients for surgery. However, if there's ulceration, if there's no ulceration, we still have to be careful and really talk to the patient and tailor treatment to the patient. So to make it as simple as we can, which we always try to do, and this slide may not prove it, but we first are going to look at some blink features. Maria's group has also looked at that, and we're going to look at some features from afar. We look at the polyp and we think of our instinct, basically. Fold deformations, one of them, chicken skin, extra redness, ulceration, spontaneous bleeding, or central depression. So you can see here a fold deformation, right? There's something wrong. There's extra redness. This polyp is not giving you a good feeling as you're looking at it. And as you turn on NBI, you're gonna look for specifically for features that worry you, that will make you think, isn't there invasion? And see here nicely tethering of the folds, and then where actually is a very where is the benefit of using the virtual chromoendoscopy? You can use here, you can see here very nicely a demarcated area. It's basically where a regular pit pattern turns into a very irregular pattern, or even an absence of pit pattern. So it's very nicely shown here, and you are definitely worried about a deep submucosal invasion here. And even if we look further at this polyp and you put it underwater, as is happening here, it's actually also magnification, just putting it underwater, and you can turn on your near focus or other magnification technique to look at it more closely, and you can see probably this is not to be attempted for endoscopic resection and should be sent for surgery. We would call this JNET type 3, and you look here, this is actually a very large area, again demarcated area here, where you can see like a type 2 nice that goes to a type 3, where there's zones where there's more whitish than a completely regular color. So this is actually a sign of overt risk of cancer, and these have a higher risk of deep submucosal invasion. And as I said, it's a change from one pattern to the next. So dye-based chromoendoscopy is unlikely to add any additional benefit in detecting SMIC at the optical evaluation. So, but the absence of a demarcated area is strongly predictive for the absence of submucosal invasion. It facilitates, as we discussed, the treatment decision. So this is clearly an overt risk of cancer. You can clearly see here where there's complete loss of the vascular pattern, and we should not attempt these endoscopically. We can try and make it even more simple, and especially for starters, if you're not familiar with JNet classifications or any classification, you look for regular pit patterns. These are safe to remove. If you have a irregular pit pattern, take good photos and send them to somebody who is used to dealing with these lesions, but these should definitely be taken en bloc. But with a complete loss of pit pattern, there's no regularity at all. These patients should be getting a tattoo if necessary and sent for surgery. So just final video, yeah, not the final video, sorry, almost getting there. Very nice image again of a demarcated area here with uneven color as a nice type 3 and a JNet type 3 as well. So this as well is a high risk for deep submucosal invasive cancer. Now, just a final thing on sessile-serrated lesions. We are probably all aware of the WASP classification using MBI as well. And we look at is there a clouded surface, instinctive or irregular shapes, and dark spots on the inside crypts? Well, we have a sessile-serrated lesion, nowadays called lesion, or we have a type 2 polyp with two of the following features. That's a nice type 2. Then we also can speak of a sessile-serrated polyp. Now, why is this important? They are very hard to see. So basically, you have to look at this. This is when you've already detected the lesion. So you can apply the WASP classification once you've detected the lesion. But first thing is obviously detect this lesion, because look how subtle they are. Usually the telltale is when you see in a completely clean colon a patch of stools. These are adherent to the mucus produced by the sessile-serrated polyp. So there your attention should go to, and then you can apply WASP classification to determine if it is indeed a sessile-serrated lesion. Now, acetic acid, there's been some study, and Pradeep also has published a case on that. I'll show you in a second. But in sessile-serrated lesions, the pickup rate would be higher when you spray a very low concentration, 0.005% in the study, just to not cause cramps or even cell death of the cells, causing huge problems with high concentration of acetic acid. So they have shown an increased pickup of sessile-serrated lesions when you spray acetic acid in the colon. And so this is the one of Pradeep, used for delineation of the sessile-serrated polyp. You can very nicely see them. They really get white, and you the delineation in these lesions is very important to completely remove them and leave nothing behind. One more thing maybe here is cell-ulcerated lesions with dysplasia. These evolve very quickly to cancer. So we definitely have to be aware of those. And what we see is actually two pit patterns. We see an area where there is a change of pit pattern. Here you can nicely see the mucus cap, and here you see an adenomatous type lesion. So don't be mistaken to only take off the adenomatous part, because this is the entire polyp, and leaving this behind will lead usually to we think an interval cancer. That's published a lot on this. But these are very beautiful lesions and we shouldn't miss them, but we should definitely remove them in their entirety. So we can detect dysplasia within SSL. That's been studied by Michael Berg's group, and you can detect it as compared to the gold standard of histology with an accuracy of 95% and a negative predictive value of 98%. And then you can remove those lesions with Holzner EMR. To conclude, maybe I think high definition scopes are what we need, and in very specific cases, definitely in polyps where our blink reflex says something's wrong here, use a virtual chromoendoscopy and go look at those areas very carefully. So thank you very much, everyone. And also, not to make promotions, but as Pradeep did it, I'll do it as well. Geeks for everyone who's interested in endoscopy. Thank you.
So thank you very much for this comprehensive review of everything in the colon and on Chromo. There are some questions that are here in the chat that I wanted to ask you, and they are mostly related on the IBD screening of dysplasia. What do you think about using putting the methylene blue or the indigo carmine in the water pump and using the Chromo through the channel, the water pump channel?
Just not a spray catheter. That's what they say. That's what they ask, not a spray catheter.
Exactly.
Well, I never do it using the water pump. I don't know if any people if any of you do it. Spray catheter is obviously very elegant. Your concentration, you know exactly which concentration. If you do it in your large water pump, yeah, you can also have, but it's maybe more diluted. And the thing is, you only need about 100 cc to spray the entire colon. So why would you fill up a whole water tank?
Yeah, what we do, Lobke, is that you put a little bit of blue. I usually use indigo carmine in the water pump, so it's really much more diluted, as you say. But on the other side, you don't have, because when you are using a spray catheter, you are doing this kind of thing that you do the spray catheter, then you take it out, then you put the biopsy or the cold snare forceps, and then you take it out, and then so, and the other way around, your accessory channel is free, so you can use I usually put indigo carmine in the water pump, and that makes you this little very light blue that will already help you to see the nominate lines, and if there is a lesion or there is an area that you want to go further, then you add more, and then you can do it with a spray catheter, or you can just do it through the channel.
No.
And it is true that as you were saying, with the spray catheter is really much more precise, probably. But on the other side, some people stop to use it because they find it cumbersome. Then the trick of the water pump can be an intermediate solution. And I have never used it with methylene blue, but I have used it with indigo carmine. I think that with methylene blue, maybe it's not so because with methylene blue, you need to remove the mucus and you
Yeah.
need to clean it up. So it's a little bit difficult that the water that you use to clean is the water that you use
Yes.
to dye. But with indigo
Yes.
carmine, if you have a clean colon, but you need to have a clean colon, I think that it's
You
a
need it. Yeah, you need it anyway. Indeed, you need a
Mm.
clean colon, or probably
It's very-
nothing works very well.
and as well on IBD, they are asking, do you take biopsies in lesions that you presume that are endoscopically removable in IBD as well?
Yeah, just one or two. I usually never take biopsies of any lesions in the colon because I think your optical diagnosis is sufficient. You take good photos and you put them on a dedicated list to remove them. However, I think in IBD it's a little bit different. It's much harder to see. You have yeah, it is already scarred, the colon. Usually you will not really further impede resection. I think it's already going to be difficult, and you're not going to take huge biopsies from the center, just a few smaller ones at the edge. Yes, we still do it. You don't?
Yeah. I think that IBD it's a little bit of different scenario of the rest. IBD, it's
Absolutely.
really when a colon is normal, let's say it has a very small chances of having dysplasia, but unfortunately the ones that have a lot of chances to have dysplasia are usually very unstructured colons with a wall that is really thin, with a lot of submucosal fibrosis. Everything is difficult.
Everything
So
is
then lesions are really flat. So everything is difficult. So that's maybe
you will
the unique situation where sometimes you will take biopsies and not remove to make sure that it is not regenerative tissue, it's really dysplastic
exactly.
before, because you can have complications quite easily. So
Yes.
you need to be it's a little bit, it's the only scenario where we still
Yes.
stand with the old way of working. I do agree. And as well, I don't know, but you already explained it. Even if the guidelines say that you can do it with virtual chromoendoscopy, I would say that in IBD is a field where clearly dye-based
Yes.
is much more helpful. So unless you are very experienced,
Exactly.
I will tend to go to also to chromo. I do agree with you.
Yes.
Um,
Yeah.
so there is a question here, Silvia, very nice to see you there. Silvia Sandaloneu asking about Lynch syndrome patients, and if it's really useful to use indigo carmine or not in those patients.
I think if you have the latest of or high definition endoscopes, I don't do it, to be honest. I use high definition endoscopes. I will not tolerate one of our older scopes we still have in our department. Will absolutely not tolerate those in these patients. I don't know, but these patients often have those very like chameleon lesions, right? I find that non-granular, hard to see. You need your best scopes. They're young patients. The stakes are high, but I don't think that indigo carmine will make the biggest difference.
Yeah, probably and the difference with IBD is that in IBD you can have lesions that that don't have a special vascular pattern. It's more very
Exactly.
flat lesions that it's just a geographic change, a little bit what Pradeep was showing when he was showing these lesions in the esophagus, that you really are very subtle. But for Lynch syndrome, what you will find is normal adenomas, which can be
Yes,
very tiny, but it's more about the withdrawal technique and the inspection technique, and about learning to detect flat lesions. And probably if you
take
don't
your
have a good,
time.
yeah, and if you don't have a good scope, again, it's better to use chromo. And if you are not experienced as well, because there is some kind of learning effect of using chromo, you learn to detect more subtle lesions, but it's not such a big thing. And then I have another question. which always strikes my attention, because the images with acetic acid on cis-ulcerated lesions are very, you can really see them very much.
Yeah.
But at the end, it's like directed, a target mode, because you need to suspect it. Have you
Yes.
ever sprayed pancolonic spraying with acetic acid?
No, the study I showed before those on the previous slide of those two examples where they spray on the lesion to delineate it, they had done the study where they sprayed it in a very low concentration because it can cause side effects. And they said that the pickup, especially for cis-ulcerated lesions, was higher, significantly higher. I've never done it because, again, I think it's knowing what you're looking for, especially with the cis-ulcerated lesions. Like it's knowing that when you have an interruption of your vessels, although you don't see the clear lesion, but the vessels that are spread along the colonic mucosa are interrupted. Have a careful look. Stools in a completely clean colon, not normal. Have a look. So yes, I have never used it. I have found it for this presentation. Full disclosure.
Good. Good. So let's wrap up, because we are already 5 minutes late, but there is still a lot of people connected. Just as a last conclusion, what is in your daily day or whatever, when do you use chromo, still chromo, dye-based chromo in your patients? In which ones do you use it?
So apart from IBD, and we're talking only lower because upper is different, but apart from IBD, not often.
Okay, good.
Not often.
Good, thank you.
To say maybe never.
Okay, thank you. Thank you very much, Lobke. And I
Thank you.
think it has been a wonderful chat with a wonderful webinar with a lot of participation. Thank you for your questions, and thank you for being there. So, and thank you, Lobke and Pradeep, for your wonderful presentations with very clear messages. And I hope that you have enjoyed it, and it's time now to finalize. And I want to show you a few slides promoting, first of all, ESGE Days. It's in Barcelona, my city. So please come by, and know that your early bird registration will finalize in February the 10th. So don't forget to do that registration. And also, if you want to learn more, many of those things that have been explained here will be in the ESGE Academy. You need to become member of ESGE, and then you will have free access. And it's incredible all that you will be able to see there. So I invite you to do it as well if you are young, and you are still young, and you are lucky for being that as young. You can join as a young member at ESGE with a lot of benefits. And finally, to tell you that there will be a new next webinar will be in 1 week, in the Wednesday 11th of December, at the same time as today, and it will be on papers of the month. So we will see what they are going to talk. And thank you to the webinar team, David and Vaso, that organized this so thoroughly. So thank you very much to everyone, and good night.